ICM Masterclass. We're here again on the ICU with Mr. Miller. The 55-year-old man had a cardiac arrest and an acute kidney injury. Due to respiratory insufficiency, Mr. Miller had to be endotracheally intubated and ventilated again. The chest X-ray of Mr. Miller showed new diffuse bilateral infiltrates, so he continued to fail all spontaneous breathing trials and remained intubated. Further, he developed a new fever and also his oxygenation worsened due to infection disease. Blood and urine cultures were sent and we started a broad-spectrum intravenous antibiotic. We've been previously down to an FiO2 of 30%, but this fraction had to be increased to 50. Also, the PEEP is going to be increased from 5 to 10, as well as the peak pressure. The neurologic status of the patient was evaluated again, so we did a CT scan, and due to unknown patient outcome, we just decided to evaluate the patient's status in an ethic case review in the following days. Until this, we're going to freeze the current therapy. And now, when we look on the curve, first we look again at Mr. Miller's infusions at the top. We'll start with catecholamines. Norepinephrine is running at a rate of 0.05 microgram per kilogram per minute. Mr. Miller is sedated with propofol 2% at 10 milliliters per hour and remifentanil at 0.05 microgram per kilogram per minute. The basic infusion is lactated ringer at 21 milliliters per hour. And the parenteral nutrition is running at 84 milliliters per hour. For continuous anticoagulation, heparin is running at 2.0 milliliters per hour and is regularly adjusted due to corresponding partial thromboplastin time. The patient also receives a continuous antibiotic infusion with piperacillin tazobactam at a rate of 6.3 milliliters per hour. If we now look at the vital signs in the curve of the morning, we see a patient with a stable blood pressure, but the pulse is relatively high. Somewhat striking are the low urine portions, but if we look at Mr. Miller's body temperature, we see that he has a high fever, which could explain the marginal diuresis. The heart rate is about 130 beats per minute. The oxygenation is about 90%, and the interior blood pressure is with a systolic pressure of 130 and a diastolic pressure of 90 quite normal. The respiratory rate is about 15 per minute. Looking at the urine output now, we see a very little and concentrated urine, most likely in the context of his acute renal failure, but also in the combination with a high fever. Looking deeper at the ventilation settings, we see that Mr. Miller is ventilated in BiPAP mode with moderate pressures. Below the ventilation settings, we find the dialysis settings. In 1 minute, the dialysis pumps 150 milliliters of blood to get rid of toxins in countercurrent. Within 1 hour, 50 milliliters are squeezed out as ultrafiltrate. This dialysis procedure is carried out continuously. Only after 72 hours, the dialysis system must be replaced for hygienic reasons. If we now assess the blood gas analyzed in a structured way, the slight acidosis at pH of 7.31 immediately stands out. PO2 and PCO2 are out of the norm as the calcium. Basic Ces and bicarbonate are lowered to borderline level and are also responsible for the low pH. The hemoglobin is also clearly too low at 8.6. His blood sugar is slightly elevated, but the other electrolytes are otherwise within the normal range. Coming to today's lab. If we look at the kidney function, we see that the retention parameters are slowly recovering under the dialysis. The coagulation situation is stable under heparin therapy, but we see a markedly elevated CRP as well as the rising procalcitonin suggests an acute new infection which also fits with a high fever. And also the leukocytes increased within the infection.
I think you can share your presentation now. It should work.
Yep, let me try. All right, hi everybody. So I hope we get this started right. Let me check. So can you guys see everything?
Yes.
Just give me a second. All right, so you guys see everything now? Perfect. So thanks for having me, guys. My name is Dr. Carlos Metz. I'm a consultant at Völkling Medical Clinic and work there on a interdisciplinary intensive care unit. I'm a specialist in respiratory medicine, was trained in respiratory medicine, intensive care medicine, and infectious diseases. And I'm going to be talking to you about a topic dear to my heart, which is pneumonia, and especially ventilated-associated pneumonia. It might not be the most sexy topic or appealing topic, but it's definitely something really important. And most of you who have worked on an intensive care unit or will be starting looking at a career in intensive care medicine will be confronted with this topic very often. So I hope we get into a nice discussion together later. And well, I hope everything works, especially with Slido. Don't know if that worked right. If not, we'll be talking the questions in a different way. So let's get into it. Gonna start off with a case of my own, not the case you've seen in the video. Just starting with a 67-year-old patient. I met him at the university in my time there, and he had a T-cell lymphoma. It was treated with chemotherapy and was destined to go to stem cell transplantation. He had some typical comorbidities and had already been treated with antibiotics. The patient was on the oncological normal ward and was then transferred to ICU because of respiratory failure, mainly due to hydropic decompensation and kidney failure. The patient we tried to stabilize him with high flow oxygen therapy, but we failed. So unfortunately, we had to intubate him. Then later we started with antibiotics, started him very broad with meropenem and tigecycline because the patient had been through many antibiotic courses before and we were expecting maybe difficult pathogens. But the patient worsened, developed severe septic shock and ARDS. Of course, he was immunocompromised severely. And unfortunately, the patient died 5 days after the admission to the ICU. It's unfortunately not an uncommon case. We see the radiological course. The first picture on day 1, we see a hydropic decompensated patient. Now, definitely, he might have some infiltrate there as well. But on day 4, we've seen multiple infiltrates on both lungs, mainly on the left lung. And yeah, he's already intubated. He has got many catheters inside. He even got a pulmonary catheter inside. And well, unfortunately, the patient didn't survive. And let's get to the cause of that. I already told you we started a very broad antibiotic treatment, but we drew blood cultures and respiratory material as well. And we see an antibiogram there. And we see many bacteria, complicated bacteria, Pseudomonas, E. coli, and we see Klebsiella pneumoniae, and we see 4-MRGN, and we see carbapenemase there as well. I'm going to be talking about that later. It's an enzyme which is able to destroy antibiotics like meropenem, which are very broad, and they have a very, very bad resistance. So we treated the patient without knowing that with the wrong medicine, and that's why antibiotic treatment failed and the patient died. So we'll be talking about that later on, just as a quick case. So why are we talking about pneumonia that much? Because it's one of the leading causes of death worldwide. It's always top 5 number 3 or number 4 in 2020. And we haven't gotten much better by treating infectious diseases. It's the most common infectious disease in industrialized countries as well, and one of the leading causes of death worldwide. So now I'm trying to get you guys into a Slido there, and I think it works. Is that correct? Can you guys see the Julia, can you see the question?
I can see the question and the QR code, so I think it will
Perfect.
work.
So I'm gonna give you guys some time. Julia, you tell me when you think you guys answered correctly, and then I'm gonna continue. I'm gonna give you some time. So the question, as we said, is you get the patient 50 years old after cardiac arrest outside of the hospital. He's on day 3 now. Respiratory situation deteriorated. He develops a fever. What are you guys doing? So Julia, when you tell me when I should go on.
It looks like almost half of the
Half of the
people
class have, okay.
Yeah.
Oh, there's some coming. So 26. So should we continue? I don't want to bother you guys evening too much. So let's get to it. You can still answer. Yeah, perfect. So just to give you a quick comment, that's all the stuff I want to be hearing. You can choose more answers. It's not just one correct answer, but exactly. Microbiological sampling, very important. Perform a chest X-ray, of course. Great answer. Draw blood cultures. Exactly. I got that one in twice. Start on one antibiotic straight away, just 3%. I don't think it's the best idea. And just because we're in cardiology, we don't need to take that patient to the cath lab immediately. So very happy with the answers there. So perfect. So let's get into the definition. Pneumonia is differentiated into some underforms right here. Well, the most common is community-acquired pneumonia. That's pneumonia which is acquired outside of the hospital and with no contact with a hospital or being hospitalized in the previous 3 months. We'll be talking about a specialty of hospital-acquired pneumonia, which is the ventilator-associated pneumonia. So it's an onset of the pneumonia 48 to 70 hours after the patient has been intubated. Yeah, I'm not going to talk about that too much, but ventilator-associated pneumonia has to be differentiated between ventilator-associated tracheobronchitis, which doesn't have any signs in chest X-ray, for example, but it's also, if you look with a bronchoscope, for example, it's an endoscopic infection in the airways. There's also pneumonia in the immunocompromised, which is the patient I showed you before, the patient which was under chemotherapy, patients who have many difficult pathogens, for example. And there's something we're not using in Germany and Europe too much, which is healthcare-associated pneumonia. That's, for example, people who are in nursing homes and develop pneumonia there. It's a subform which is used in the United States to qualify pneumonia, but we don't use it in Europe and Germany. So we're going to stick to community-acquired, hospital-acquired, and pneumonia in the immunocompromised. And the topic today, of course, is ventilator-associated pneumonia. Why is that important? This definition or specialization, I'm not too keen about talking about definitions, but it's important because the definitions relate to different pathogens causing the pneumonia. So community-acquired pneumonia, we're expecting different bacteria or pathogens as in the hospital-acquired and the pneumonia in the immunocompromised. So that's why this definition is quite intelligent in my point of view. So ventilator-associated pneumonia, like everything in medicine, there's many guidelines. There's a new recent German guideline from last year. There's a European guideline for the European Society of Intensive or Critical and Intensive Care Medicine, and there's an American guideline as well. I'm gonna, because this is an international course, I'm gonna look at all the guidelines a little bit, but I'm not gonna try to bore you too much. So why is this important? Hospitally acquired pneumonia is the most common infection you can get in a hospital. So just in Germany alone, we have 140,000 cases, which is well documented in the German health system. And we could say 5 to 20 cases per every 1,000 admissions develop a pneumonia in the hospital. 1/3 of all the hospitally acquired pneumonias are ventilator associated. So the incidence on every ventilator day or on every 1,000 ventilator days is 2 to 16, which is quite high. And there's a high incidence throughout every form of intensive care medicine. Well, I especially work in cardiologic, cardiothoracic surgery, and of course, respiratory medicine, intensive care medicine, and we see it there a lot, but especially in trauma and brain injury patients, we see many pneumonias as well. So it's a topic concerning every type of intensivist. It's got a huge economic impact as well. Every case of hospital-acquired pneumonia costs about $40,000 more, and the length of an ICU stay is increased by 7 days in the median. So that's quite a lot. The mortality is quite hard to predict because there's many causes of mortality on an intensive care unit, but the attributed mortality, so strictly caused by ventilator-associated pneumonia, lies around 10%. So a high mortality as well. This goes along with ST elevation infarction, for example, in the German mortality. So how do we acquire ventilator-associated pneumonia? So the patient has to be intubated. We put down a breathing tube through his windpipe, which we see here on the picture. And we see there's a bacterial film on the tube, and bacteria can move down right here, can move through the lumen, of course, and will always be bacteria just right above the cuff. And when the cuff moves or the cuff gets deflated, they move down the windpipe. Of course, patients are mostly or many times sedated, so we have no mucociliary clearance, or the cuffing of the patient is reduced. So this is a very unphysiological state in which the patient is in. He's vulnerable, maybe due to his other illnesses, which he is on the intensive care unit for. So we get many problems with the physiology and the immunosuppression. So just that you guys have an impression about what is happening right there. So we see the pathophysiology, but now how do we know a patient has ventilator-associated pneumonia? The German guidelines have a diagnostic bundle, which is quite easy. So we have major criteria and minor criteria. What's the major criteria? We have a new infiltrate, either on the chest X-ray or on the CT scan, plus 2 of the following minor criteria. That means we have fever, leukocytosis or leukocytopenia, and we have new purulence secretion. Okay, so a new infiltrate and 2 of the 3 minor criteria, and we would be talking about ventilator-associated pneumonia. If we look at invasive microbiological sampling, so we have down here, I have a picture of a bronchoscope right there of the right-sided main bronchus, but it's not necessary. You can aspirate tracheal secretion as well, and if that's pruned, you can already talk about ventilator-associated pneumonia as well. So you don't have to perform bronchoscopy, which is unfortunately not possible in every hospital. So diagnosis of VAP has a few things. So I want you to look at these 2 pictures right here, and just have a look. I will give you guys some time. What will you guys be thinking? What are we looking at? And then when you guys are ready, maybe you've seen the pictures right now, have made up some ideas, and then I would go into a question straight away. So it's an open question I asked. What would be the answer, or what do you guys think are the pathologies in the two pictures? There's different possibilities of what you guys can answer. Pneumonia is a good idea always if we talk about that, exactly. Great answers. Many, the radiologists and respiratory care physicians, everybody pretty good. Oh, sorry, guys. So I'm gonna solve the problem. I've seen many good answers right there, and we might discuss that later. So picture A is a complete atelectasis of the right lung. Many of you wrote that, and on the left, or picture B, is great answers. Pneumonectomy, it's a good answer as well, but it's an atelectasis, and we can talk about it later. You see the volume of the right lung, which is usually the larger lung, is diminished. The trachea is pulled over to the right side of the patient, and you still see some right main bronchus. So it's not a pneumonectomy. So that's not the case. You could think about an effusion. If you use sonography, you will be 100% sure. I would be sure just by looking at the chest X-ray in A, because the lung volume is diminished, the trachea is pulled to the right side, whereas in a pleural effusion, the volume would be bigger and the trachea would be pulled over to the other side more. And picture B is a lobar or bronchopneumonia, just as you guys called it, so new infiltrates on the left side. Exactly. So we have on one side a complete atelectasis of the right lung, and on the other side we have a pneumonia and new infiltrate. So, but all great answers. Pneumonectomy, it's a great idea. Consolidation, it's a right term. So I see many good ideas. So let's keep on going. If we talk about diagnostics, I'm gonna make it quick. This one, not gonna run you through all of this. What I want to be telling you guys, VAP, or ventilator-associated pneumonia, is always it's almost a differential diagnosis. And when you say it, you have the impression it might be ventilator-associated pneumonia. You're just right in about 50% of cases, because there are many differential diagnoses, just as we looked at that. It's atelectasis. We can have pulmonary edema. We can have pneumonitis of some sort. We can have a pulmonary embolism with infarction pneumonia. ARDS, for example, a cryptogenic organizing pneumonia. So there's many things, and something, just a clear maybe suggestion I would give you, but in general, not just for this subject, always review your diagnosis. Think about it. Maybe could it be something else? So if it's possible, then look at it. How probable is it? And if you have the strong suggestion, then think about it, treat it, but always ask yourself, could it be something else? So always keep open-minded and always be critical with your own diagnosis as well. That's just a general suggestion for medicine and intensive care medicine, especially. So I think this one went wrong. Name common pathogens for VAP. No, it's right. Just choose the ones you would say are common. So exactly here, ventilator-associated pneumonia. So what is common in the hospital, which are not common in the hospital? Julia, is it too quick or should I go on?
I think you can go on.
All right, so let's check what you guys answered. Perfect. All specialists right here. So Klebsiella is typical for ventilator-associated pneumonia. It's a gram-negative pathogen, as well as Pseudomonas. It's one of the top 3 pathogens or bacteria in ventilator-associated pneumonia, especially in patients with structural lung disease, COPD, cystic fibrosis, bronchiectasis. Exactly. Staph aureus, of course. It's really common as well, especially in the United States. It's more common than in Germany, and there especially MRSA, so methicillin-resistant Staph aureus, is a problem. Legionella, it's a rare but possible pathogen for community-acquired pneumonia, especially in Germany. We see it from when people have been traveling abroad, maybe to Spain, Southern Europe, or North Africa, for example, been having a holiday where they have air conditioning, for example, or been into jacuzzis or something like that. So it's not typical in the hospital. It can occur, but really atypical. And Chlamydia psittaci is something, it's a bacteria acquired, for example, people who have birds. So it's very untypical at the hospital. So great answers, guys. I would rate them exactly the way you rated that. So here I just got an overview. Don't bother too much about all the studies and figures. But what I'm trying to tell you guys right here, we've looked at studies from all over the world, and the top pathogens are Staph aureus, maybe thank God, methicillin's sensible or susceptible Staph aureus, Pseudomonas, E. coli, and Klebsiella and Enterobacteria are the most common ones. So just the ones you have named. So I think you guys are pretty well informed already. So what we saw before, the first case I presented to you guys is multi-drug resistant pathogens. So when are we thinking about multi-drug resistant pathogens? And the important question then is, if we're thinking about it, how should we treat this? So who is at high risk of having multi-drug resistant antibiotic resistance? Well, those are patients who've been having intravenous antibiotic treatment within the last 90 days. Patient at septic shock or patients having an ARDS preceding the ventilator-associated pneumonia. People who have been on renal replacement therapy, for example. Then people who have been known to have multi-resistant drug bacteria in the past, or people who've been treated, for example, in regions at risk like Europe or especially Asia and the Middle East. Or as well, something you should always be aware of is know your local hospital. So if you have a high incidence of multi-drug resistance in your ICU or in your hospital, you should always think about it. And of course, what we've talked before, structural lung disease. People who are having a COPD, cystic fibrosis, in general, are more likely to have pathogens like Pseudomonas, who have already a big multi-drug resistance within themselves and can acquire resistancy very easily as well. So always think about your patient. Is he at risk of having that? And from that point, you should choose the weapons, the antibiotics you will be using, okay? So the epidemiology of multi-drug resistance in Germany, this is some old data just until 2015. I can give you the new facts as well. It's steadily rising, and of course, it's increasing a lot. The trend we see here, it's going the same way. We have a big increase in especially in E. coli and gram-negative Klebsiella, but we see a strong decrease in MRSA, methicillin's resistant Staph aureus, which is quite good. It's a bigger problem in the United States, for example, but the problem we're having here in Germany and the whole of Europe is gram-negative bacteria, multi-drug resistant gram-negative bacteria. So the main topic and the main pathogen for ventilator-associated pneumonia is it's a bacterial infection. A viral infection is possible, but it's very uncommon as a source of ventilator-associated pneumonia. Something we must think about is a fungus, which is Aspergillus. So when you sample bronchial aspirate or bronchial sputum in your hospital, and people are under antibiotic treatment, you will see Candida, for example, living in the bronchial aspirate many times. We don't treat Candida in the lung because it's just a form of colonization, but something we should be treating and should be thinking about is aspergillosis. Who is likely to have aspergillosis? These are people who are very, very sick, just as you see here, with higher illness severity, the likelihood of aspergillosis goes up. Those are mainly patients who have a strong immunosuppression, mainly patients who've been going through chemotherapy, especially treating their T-cell suppression, and patients who've been intubated, for example, for influenza or COVID-19 ARDS. It's a lot more common in influenza, and I remember the influenza wave in 2017-18. In Germany, almost 30% of influenza ARDS, severe ARDS, later on had a ventilator-associated pneumonia due to aspergillosis. So that's something you should think about and address with a antifungal treatment. So keep in mind, bacteria are the most important sources or pathogens of infection, but in some small cohort of patients, always think about fungal pneumonia as well. Other causes are very, very, like viral causes, are very unlikely. All right. So before I'm talking about that, I would like to listen to your opinion on preventive measures against ventilator-associated pneumonia. So here are some answers. To give it to you quite clear, the most preventive measure against ventilator-associated pneumonia is not intubating a patient. So I know it sounds logical and it's a stupid answer, but if it's possible, always try not to intubate a patient and have him on non-invasive ventilation, for example, or high-flow nasal cannula, if it's possible, of course. So what can a doctor and the nurses do to prevent ventilator-associated pneumonia? That's the question. All right, so let's check your answers. I think the questions are too easy. If I'm looking at the answers, everything is pretty correct. So the one you've named the most is oral hygiene with chlorhexidine. Evidence is not that strong. There's some little evidence, but of course, oral hygiene is very important. Exactly. Early mobilization, it's good for everything. It's good against delirium. It's good against ventilator-induced diaphragmatic insufficiency. It's good against critical care or critical illness polyneuropathy or polymyopathy. Spontaneous breathing trials and sedation holidays, of course, are important. I don't know, have you heard Andreas Meiser's lecture about mechanical ventilation? Has that been a topic yet?
Yes, it has.
So you guys know spontaneous breathing is the most important thing. Exactly. Deep sedation to avoid aspiration, it's complete nonsense. Exactly. Deep sedation is in a very few cases, a patient has to be deeply sedated, but in general, it's not a good idea. And volume controlled ventilation rather than pressure controlled ventilation, it's nonsense as well. There's no data for that. So we're looking at the evidence. So the most important is not to intubate, non-invasive positive pressure ventilation. It's a good idea to avoid ventilator-associated pneumonia. Interrupt sedation daily, of course. Extubate when ready, of course. Spontaneous breathing, high. It's logical and it has got evidence as well, but we shouldn't forget in evidence-based medicine that logical thinking is still allowed, and there hasn't got to be any evidence for something if it's logical and physiologically. Okay. So an elevated head, 30 to 45%, has low evidence, but of course it helps. Something which is very interesting, which you guys see here, is selective oral or digestive decontamination. It's something which has been practiced mainly in the Netherlands. What they do 48 hours before, for example, cardiothoracic surgery, patients get antibiotics which only work in the gut and are not taken in systemically. And with that, the evidence or the incidence of pneumonia was a lot less. But it just worked in the Netherlands. It never worked in other studies in other countries. So it's a paradox, but it's something very interesting. And in cardiothoracic surgery, there's still some hospitals, even in Germany, which use that practice. I've used it as well in my hospital, and we've had some good results, but it's very controversial. Okay. So regular oral care with chlorhexidine has moderate evidence, but it works as well. Good nursing is very important to prevent ventilator-associated pneumonia, but it's hard to say how that works, how to show that with a study, for example. And how is it with subglottic suction, for example? There's moderate or low evidence for that. And there's no evidence for different tubes, a little bit for silver-coated endotracheal tubes, which are very, very expensive. So there's not that much evidence for that. That's a new topic, which has come out 2 years ago on the New England Journal of Medicine. It's a French study, quite big, almost 1,000 patients. And they looked at inhaled amikacin, which is an antibiotic, just as gentamicin or tobramycin. It's a newer generation, and it can be inhaled. And they used that on the patients who were intubated. They had a cohort which was getting placebo, and the other one was getting inhaled amikacin. And if we looked at the graphs right here, these were the x-axis is the time, and here it's the incidence of ventilator-associated pneumonia. And the guys who were getting placebo had almost 22% rate of ventilator-associated pneumonia, which the inhaled amikacin group had 15%. So these are quite promising results. To be honest and to be fair, inhaled amikacin is very expensive because it's given in a liposomatic form, which makes it very expensive. But it might work with tobramycin or gentamicin as well, which are far less expensive, and it might work as well. But it's an interesting study. It's pathophysiology. It's quite intelligent how they did it, but still it needs to be proven in a larger study. And of course, always stay critical. If a pharmacological firm is performing a study, they want to show that their new drug is working. So as doctors, always keep in mind that you have to be critical with everything you read. All right, so the out-of-hospital cardiac arrest patient we saw before with acute cardiac syndrome, 3 days in, now he's got ventilator-associated pneumonia. What antibiotics would you guys use? Many options you can choose. You can choose all of them. Give you some more time. Very, very good results. Quite like it. And it shows me generations are changing. All right, so I'm gonna start with the comments. So piperacillin tazobactam, of course, it's now the most common used antibiotic in German hospitals as an intravenous antibiotic. So Julia, who is doing the moderation today, she used to work as a nurse on the same intensive care unit as I did. And when I started, more than 10 years ago. It was an antibiotic which was just used for very severely ill patients with high risk of multi-drug resistance bacteria, and now it's being used very liberally. So Pip/Tazo, it's right. The one I would choose for these patients is just ampicillin sulbactam. I still use it at my hospital for all out-of-hospital cardiac arrest patients or patients who come from outside and have been intubated. There's even a study, the Arctic study, which was performed on patients on out-of-hospital cardiac arrest. It showed a better mortality if people were treated with an antibiotic, because during reanimation, aspiration is really common. So I usually tend to treat patients who've been intubated preclinically after reanimation with ampicillin sulbactam, for example. Meropenem, it's of course possible, especially in patients who we are expecting multi-drug resistance or have been treated with antibiotics before. It's a good choice. Ceftriaxone and gentamicin, it's not typically. Ceftriaxone can be used, no problem, in ventilator-associated pneumonia. It's part of the guidelines, but the combination with gentamicin is not very common. So it's possible, but I wouldn't choose it as first step. Vancomycin alone, it's not a good idea. It strictly works for gram-positive bacteria, and azithromycin, it's almost an add-on for severe community-acquired pneumonia, but should not be used in ventilator-associated pneumonia, and especially not as a monotherapy. So let's get into the guidelines. What do they tell us? Here we have to differentiate a bit between the United States and Europe. So in the States, they have more problem with MRSA in the hospitals and from the community as well. They have community-acquired methicillin-resistant Staph aureus. So in the United States, usually ventilator-associated pneumonia is treated with a combination of an MRSA active agent like vancomycin or linezolid with, for example, a gram-negative active anti-pseudomonal beta-lactam like Pip/Tazo, cefepime, ceftazidime, meropenem, or imipenem, for example. So always a combination, but having a stronger look at the gram-positive bacteria, mainly MRSA, which is a very uncommon thing in Germany. Maybe in over 10 years of respiratory intensive care, I've maybe seen 5 MRSA pneumonias in Germany. So it's not very common, to be honest. So if we're talking about anti-pseudomonal activity, there's a big debate, controversial debate, or if we should treat these patients with a double coverage for Pseudomonas. I don't have the truth right there. It's possible. I don't tend to treat every Pseudomonal pneumonia with 2 antibiotics, but it's possible. So if you're talking anti-Pseudomonal activity, you could use a combination, for example, meropenem and aminoglycosides like amikacin, gentamicin, tobramycin, or even the fluoroquinolones. But always bear in mind that fluoroquinolones have many side effects as the aminoglycosides as well. So be restrictive on that. I tend to use only one anti-pseudomonal beta-lactam-based drug if it's possible. So United States, keep in mind, more gram-positive problems with MRSA. The rest is quite identical to the German guidelines. I kept the table in German. It's from the original guideline. So let's talk about the duration. How long do we treat ventilator-associated pneumonia? Usually 7 to 8 days is sufficient, not too long. That's something we'd see in almost all infections. Less is better. De-escalation, according to microbiological results, especially in septic shock, start strong. And when you have the pathogen, then you can always de-escalate the therapy. Always perform clinical reevaluation of your therapy 48 to 70 hours later. And don't just treat CRP or procalcitonin. Treat the patient. Is he getting better? Are vasopressors going down? Is respiratory situation getting better? Has fever dropped? So those are the things we want to reevaluate. We're not treating the labs. So don't just look at CRP or procalcitonin or interleukin-6, whatever you guys are using. And if there's any evidence for MRSA, as well in Germany, add vancomycin or linezolid, but it's not a must-have in Germany. So just as we said, patients who are not in septic shock and have no risk of having multi-drug resistance, this is what MRE means. Ampicillin, sulbactam, it's a great choice. Ceftriaxone is a great choice. Cefotaxime has got just the same, has exactly the same spectrum, but it's giving 3 to 4 times a day, whilst ceftriaxone can be given once daily, which makes it easier maybe for nurses as well. Fluoroquinolones are possible, but should be never given alone in ventilator-associated pneumonia and have many side effects. And there's some black box letters as well, so keep that in mind. And if you have a risk for pseudomonal active or pseudomonal activity in the pneumonia or other multi-drug resistance, then think about Pip/Tazo, cefepime, so 4th generation cephalosporins, and meropenem. And if you're in septic shock, think about meropenem, for example, or a combination therapy, for example, Pip/Tazo plus ciprofloxacin or MRSA, or meropenem plus ciprofloxacin. So keep in mind, is there any risk for multi-drug resistance? Then you start a more broad antibiotic. And in septic shock, maybe combination therapy, or start very broad and then de-escalate according to your results. So the big difference, as a key message, the big difference in treatment between Germany and Europe, and especially Germany, is the higher risk of having methicillin resistant Staph aureus, which is not a big problem in Germany anymore, thank God. So now something which is a general key learning I want to give you guys is, of course, using the right antibiotic, but using it correctly and at the right time. So you all know, start early. If you're thinking about severe infection, mortality increases as the more you prolong the start of antibiotics. So this is a study from CHEST. Not that a big number of patients, but VAP motility, if antibiotic treatment was started within the first 24 hours, which is still quite long, mortality was 11%. If it was decreased over 24 hours, mortality was almost 40%. So we know that for community-acquired pneumonia as well, if you're thinking sepsis, if you're thinking ventilator-associated pneumonia, start antibiotics soon. And the best study, I think, for the start of antibiotics was the Kumar study from 2006 in critical care medicine, which was shown for septic shock. And it's a very short study. If you guys ever have time to read it, it's 3 or 4 sides long only, and it goes out with 2 graphs. And this is my favorite one, for example. So on the x-axis, you have time. On the y-axis, you have the fraction of total patients. Black is the survival fraction, and gray is when the effective dose of antibiotics was given. So if antibiotics were given in the beginning, the mortality or the survival was over 80%. So start early, patients survive. If you look at the antibiotic was given in the first hour, it's a very poor fact. Only not even 10% of patients in septic shock got an antibiotic in the first hour. And if we look at here, every hour we look, survival fraction goes down. And some patients, 100% of patients received antibiotics in septic shock after 36 hours. So it's still too long to antibiotics for many patients. So the key message was, the fraction of survival decreases by 7.6% every hour. So every hour you delay antibiotic treatment, the mortality goes up 7.6%. That's just enormous. So if you think you've waited 6 to 7 hours to give a patient in septic shock antibiotics, his outcome is 50% worse. So keep in mind, giving antibiotics in septic shock is just as crucial as getting a patient with an ST elevation infarction to the cath lab immediately. So here as well, time to antibiotics is just as precious as time to needle, for example, in an infarction. All right, so let's get to the complications of ventilator-associated pneumonia. Right here we have a pneumothorax. with an abscess as well. We have severe ARDS, of course. A nice picture of a lung abscess, which you see as a cavern right here. We have pleural effusion, pleural empyema. This is just straight pus coming out of the lung, and of course sepsis and septic shock. And at the end of all these diseases could be death as well. So let's get to the next question. Your patient develops an ARDS. What would be good treatment options? I know it's not the main topic, but as a respiratory guy, I like ARDS as well, and you've heard mechanical ventilation, so I would be eager to hear your thoughts on that. All right, just gonna give you a couple of seconds more. So maybe my questions were, I think they were too easy, but you seem to be well informed and pretty keen on intensive care medicine, everybody. So that's pretty good, pretty impressive. All right, I'll start commenting on everything. So use protective ventilation. The ARTSNet study of the early 2000s, protective ventilation, low tidal volume, 6 to 8 mils is better than 10 to 12 mils, and prevent high plateau pressures over 30. Exactly. It's always a great idea in ARDS and in ventilation in general. Pronation therapy for 16 hours if the oxygenation index is below 150. Very good, has great level of evidence. The ProSiva study from France, pronation therapy, and mainly if oxygenation is bad, use pronation. It's a great tool, it's cheap, and it really helps with a great level of evidence. So the third one is a bit tricky. I tried to trick you guys on that one. Put the patient on veno-arterial ECMO straight away. No, not really straight away. It's probably not the right thing as well. In therapy, refractory ARDS, ECMO is possible, but we would use VV ECMO, so veno-venous ECMO, not veno-arterial ECMO, which we would use in circulatory failure, for example. This one is a controversial one. Start with neuromuscular blockage for 72 hours. So neuromuscular blockage is possible. Was a huge trial, which was then looked at the ROSE trial in the United States. Well, the French trial showed neuromuscular blockage is possible in the first 24 hours to make compliance of the lung better, for example, and to decrease ventilator or patient ventilator dysynchrony. But it's a very controversial topic. Neuromuscular blockage is possible, but it shouldn't be done for 72 hours. That's definitely too long. And nitric oxide inhalation, it's possible. It's gone back. The quality of evidence is low as well, but it's a rescue therapy and it can be used as well. But it's pretty good answers right there. So the two first ones are the most important things to remember in ARDS, and VV ECMO might be an option. All right, so I would switch the topic from ventilator-associated pneumonia a little bit to antibiotics because I'm an infectious diseases guy, and it's something topic which is very interesting. So, but I'm not going to bore you guys too much with drugs and pharmacology, just a little bit. So, are there many new antibiotics out there for ventilator-associated pneumonia? To be honest, no. If you look at what's been happening in oncology, or especially oncology, for example, we're having new drugs every year, every month, something new is coming out, especially in the biologicals. But in infectious diseases, we are not having many new tools. Cefiderocol, I'll be talking about that one, is a very interesting antibiotic. It's not the solution for all our problems, but it's very good for gram-negative bacteria. I'm going to show you why. And then we started combining, for example, ceftolozane, a newer cephalosporin, with tazobactam, so an old beta-lactam inhibitor with a new cephalosporin, and ceftazidime-avibactam is just the other way around. A 3B cephalosporin was combined with a new beta-lactamase inhibitor. Imipenem relebactam, it's the same new beta-lactamase inhibitor, especially for pathogens doing carbapenemases, so enzymes which destroy meropenem or imipenem, for example. So just to keep in mind, there's not that many new antibiotics out there and not that many promising. So I'm going to talk about ceftazidime-avibactam, which we sometimes use. I try to be very restrictive on that, but we can use it if we have gram-negative bacteria as Pseudomonas or Enterobacteria, and they produce KPC carbapenemases as KPC or OXA48 carbapenemases. If the lab detects that enzyme, we can use ceftazidime-avibactam, and it's gonna help. It's got an FDA indication for intra-abdominal infection. It needs to be combined with metronidazole because it doesn't have anaerobial function, but it works there as well. Complicated urinary tract infections and in hospital and ventilator-associated pneumonia, our topic. So keep this one in mind for gram-negative bacteria producing KPCs, for example, OXA48 carbapenemases. And now the new one, this is the Horse of Troy. You've probably all read the Ilias or seen the movie Troy with Brad Pitt, and that horse is being used there. You've probably all heard of it. And cefiderocol, it's a drug which looks or has a function of a Trojan horse. And I'm going to explain it to you why. It is attached to iron, which we see here, Fe, and bacteria need iron just as humans need iron as well. So the antibiotic is taken into the bacteria through channels which are usually used for taking in iron into the cell, into the bacterial cell. And so cefiderocol is just hiding under iron, just like the Trojan horse, and it's getting into bacteria and can destroy them there. It works for many gram-negative bacteria and for many carbapenemases as well. I've used it in some cases, not even 5 cases, and we've seen a resistance in the course of the treatment. Maybe after 6, 7, 8 days, bacteria developed a mechanism of resistance against cefiderocol as well. But in 2 patients, it saved their lives. So it's something we should use very restrictively, but it's an interesting option, and I thought it's a cool pharmacological gimmick. So I would just be interested in if you've ever heard of the antibiotic at university or ever even seen it. So that's just something interesting for me. Because I now no longer work at a university hospital, and to be honest, in the last 3 years, we've never used it there, although we have all sorts of broad spectrum antibiotics there, but we've never had to use it, which is good, which is a good development. But at the university, I've had to use it a couple of times already, especially in patients who come from oncology or other specialties where there's many difficult bacteria. All right, so some have heard it, but most of you have never heard of it or even seen it. So cefiderocol, quite a promising new antibiotic. All right, so we've talked about the right antibiotics. We've talked about using them early, but now we have to talk about dosing antibiotics. So guys, if you look at these 3 pictures, we have an athlete, we have a morbidly obese woman, and we have some old patients probably with kidney failure and whatever. And all these patients, the FDA suggests the same dosage for all antibiotics. I think all of you guys know this is probably not gonna be true, okay? But this is how we dose antibiotics, and I think we've been talking about, or the world is talking about personally based medicine, and we should start the antibiotic treatment, we should personalize that as well. So defining antibiotic levels in intensive care unit patients. So if you work in a hospital where therapeutic drug monitoring, especially for antibiotics, is possible, I would use that. There was a big study, the DALI study from Jason Roberts, who is the big guy worldwide for antibiotic dosing. And what he concluded, infected critically ill patients have adverse outcomes as a result of inadequate antibiotic treatment. A more personalized dosing strategy seems to be helpful. Exactly. So in many of these patients on the ICU, antibiotics were dosed the wrong way and were usually underdosed. So don't be scared. Or at least I would say it's controversial to say that, but usually, especially in the first 2 days, I would rather overdose an antibiotic than underdose it. So, and the risk of underdosing antibiotics is far higher than the other way around. So think about dosing. So what do we have to know to understand dosing of antibiotics? There's two pharmacokinetic and pharmacodynamic killing forms of antibiotics. So the one is time dependent. All beta-lactam antibiotics work over time. So if their concentration shown here is above the minimal inhibitory concentration, so that's the minimal concentration you have to kill the pathogen, then the best thing is to keep the concentration over this level over a long time. So there seems to be evidence for giving antibiotics continuously or even prolonged. So carbapenem, cephalosporins, penicillins can be given prolonged, and that's what even the new guidelines in sepsis say. There's the other form of dependent killing is concentration dependent killing. This is what gentamicin, tobramycin, or the quinolones do. They have to have a very high peak concentration, and then they kill the pathogen. So gentamicin, tobramycin is giving once daily. Quinolones are giving twice daily, but in a high form. So not just think about right dosing, think about giving the antibiotics the right way. So here is just as we would suggest it for piperacillin. We see in red, this is how you do it. You give it 3 times daily. You have a peak concentration, then it drops down under 4 hours. And under 4 hours, you're not killing any bugs anymore. So if you give it prolonged, you give it over a longer period, over 4 hours. And after 6 hours, then the time-dependent killing decreases. And of course, there's the form of continuous antibiotic infusion. So you're giving it throughout the whole day. The difficulty in this case is if you're giving it continuously, you have to be sure that you're above the minimal inhibitory concentration. So the danger is you're underdosing it the whole time and you're not killing any bugs. So that's why therapeutic drug monitoring is something very important. And it's a great source. So right, just talked about 1 hour now, and let's get to the take-home messages, and maybe you guys have some questions or discussions. So ventilator-associated pneumonia is the most common source of infection on an intensive care unit, and the nosocomial or hospitally acquired pneumonia is the most common source of infection in the hospital in general. The best prevention is restrictive use of invasive ventilation. So if there's an alternative of intubating a patient, use the alternative if possible. The most common pathogens are Staph aureus, Enterobacteria, and Pseudomonas. And that's important for the treatment choices as well. The longer a patient stays on the ICU, the higher the risk of multidrug resistance is. Delayed and inappropriate antibiotic treatment risk lives. So start antibiotics early and choose the right broad antibiotics in the beginning and de-escalate according to your microbiological tests. Empirical antibiotic treatment according to local guidelines. We talked about the differences between the United States and Europe, for example. And if we're talking multi-drug resistance, carbapenemases and 4-MRGN have become more common and are a big risk in our health system. And they will be killing more patients every year. And the World Health Organization has some great figures on that. So that's becoming a major problem around the world. So I think there has to be a lot more investigation and science according to that. And I think it's quite sad that we're not having that many new drugs developed for these pathogens. So prolonged and continuous infusion and therapeutic drug monitoring are some good tools to improve the quality of antibiotic treatment. And maybe if you're talking about new substances, then cefiderocol seems to be a promising new antibiotic agent for some complicated infections. So now you've heard about that drug and keep it in mind. If you ever have a patient with a severe gram-negative infection, maybe you can help the doctors or your senior doctors or residents by giving them that tip. All right. So I hope you had you profited from that, and it was interesting. And thanks for your attention. And I'm keen to hear your questions. Thank you very much.
There are some questions in the chat. The first one, how do you call a pneumonia with an onset after 72 hours after intubation?
Also, ventilator associated would be the same. It's the lower limit of time.
Okay, then the next one, what was the indication for tigecycline?
Well, we didn't in the first case exactly. Tigecycline is not a very good antibiotic for the lung. It's a great answer. I think the colleagues started tigecycline because they didn't know where the primary focus was, and maybe his abdomen was a problem. That's why it was started, but it's very uncommon. I wouldn't have started that treatment, to be honest. Very good point. Yeah. It's something you should remember for complicated peritonitis, for example, but it's got a very, very bad function in the lung.
Then there's another questions to the antibiotics. Would cefepime be a good idea to treat ventilator-associated pneumonia due to the gram-positive and negative coverage and activity against Pseudomonas?
That's a good question. So cefepime, you can till the fourth generation of cephalosporins, each generation they keep getting better in their activity against gram-negative bacteria. So cefepime, it's a good option. It's got more neurological side effects than the other cephalosporins, so I tend not to use it too much, but it's got a good function against gram-negative bacteria, but it has a very poor function against gram-positive bacteria. If we're now going up to the fifth generation of cephalosporins, like ceftobiprole, for example, that new generation of cephalosporins has a very good activity against gram-positive bacteria, such as MRSA, for example. So cefepime is something I rarely use, but it has good anti-pseudomonal activity. So you can use it for ventilator-associated pneumonia. But it doesn't have a good activity against gram-positive bacteria. That's the downside, and more neurological side effects.
Then there's another one. I'm not sure if do any meds for chronic have their MIC affected? Do you need to consider changing doses or meds for patients with chronic conditions due to the liver enzymes and metabolism of the drugs being affected?
Well, it's a good question. You will never, or it's hard to know what kind of metabolism the patient has. But if you look at therapeutic drug monitoring, then you have an option to change the dosage of your antibiotics better. And of course, you need lab testings so they can give you breakpoints or mix of the bacteria. But like the usual lab tests we have for the metabolic function of patients are insufficient. So therapeutic drug monitoring is a good choice to give better dosage. Okay.
So this was the last question of the chat.
All right.
If there are no further questions, then thank you very much for the lecture. Ah, wait. Okay. I think someone wrote wait. Oh, okay. Has someone tried bronchoalveolar lavage with antibiotics?
That's a good question. It's experimental. We've done it at our hospital. My old boss sometimes used to do it, and really bad cystic fibrosis. He used to give colistin or tobramycin over bronchoalveolar lavage. He's done that, but there's zero evidence for that, and I wouldn't do it. But something which goes into that direction is inhalative antibiotics. That's something where there's more evidence, especially in cystic fibrosis, for example. So I wouldn't be giving antibiotics over bronchial lavage. I would give them as an over inhalative form, for example. There's some data for that, and especially in cystic fibrosis. A very good question. Yeah.
And there's another one, or two. What about vibration therapy as a preventative measure?
Yeah, vibration therapy, it's something respiratory medicine loves, and many physiotherapists love as well. So in general, I would say physiotherapy, vibration, early mobilization, all of that has a preventive effect. Do it, okay? It's good. Physiotherapy is good, and vibration therapy is good as well. Not in every patient, but it works especially to clear out the airway and help the patient to cough. Good. It's always good. Yeah.
Then a question about the inhalative antibiotics, because the American Guidance for Resistant Bacteria does not recommend it.
Exactly. The evidence we have for inhalative antibiotics, it's mainly for cystic fibrosis, which is its own planet. I showed you guys the study for inhalative amikacin as preventive measure. So it's not in the guidelines, but it's a possibility you have in maybe pseudomonal infection. And if nothing else helps, or you're in a very refractory state and the patient is very critical and you don't have any other choices, then you could use inhalative antibiotics, but I wouldn't use it as a standard therapy, okay? But for cystic fibrosis, for example, it's got good evidence, and it's being used regularly. And patients with cystic fibrosis, for example, use inhalative antibiotics at home as well, more than systemic antibiotics, because you have less side effects, and resistancy tends to be lower as well. But that's a different planet. That's cystic fibrosis therapy, which is something very special. So keep inhalative antibiotics in mind, but it's not a standard therapy regime.
Then what about high frequency oscillator ventilator effect on the pneumonia?
Guys, is there just intensive care specialists here on the chat? Those are very differentiated questions, which make it hard to answer. So high frequency oscillation ventilation is not a thing in the adult respiratory failure world anymore. So we're not using that in Europe, at least we're not using it for ventilation anymore. So I don't see any effect on ventilator-associated pneumonia because we don't use it on adults. To be honest, I'm not a pediatrician. Pediatricians still use high-frequency oscillation ventilation, but for this question, I have to be honest, I don't know the data for pediatric patients. But in the adults, it hasn't got a function anymore. But great question. I have to pass out if there's data for kids. I don't know.
So are there any more questions?
So you're giving me a hard time at the end of the day now. And it's a holiday in Germany, especially. So very good. I'm happy so many people are here and asking very good questions.
But I think this might have been the last one.
Okay.
So thank you all for your questions, and thank you for the great lecture. And we
Thank
see
you. Thanks for having me.
at the next time.
Thank you. Have a great day. Bye-bye.